Welcome to This Week in Gastroenterology. This week, we're covering 8 notable papers spanning management strategies for inflammatory and functional luminal disorders, advancements and diagnostic limitations in endoscopy, and infectious drivers of gastrointestinal pathology. Let's dive in. We begin with a focus on optimizing therapy for difficult-to-treat luminal conditions. In a major network meta-analysis, researchers evaluated the relative efficacy of gut-brain neuromodulators and brain-gut behavior therapies for irritable bowel syndrome. Analyzing 68 randomized controlled trials with over 6,600 participants, they found that compared with waiting list controls, serotonin and norepinephrine reuptake inhibitors, or SNRIs, ranked first in efficacy, roughly halving the risk of global symptoms or abdominal pain failing to improve. Tricyclic antidepressants, or TCAs, ranked second, closely followed by dynamic psychotherapy and emotional processing. Other therapies like cognitive behavioral therapy, disease self-management, selective serotonin reuptake inhibitors, and gut-directed hypnotherapy were also superior to waiting list controls. However, the authors emphasize that the overall certainty of evidence was low or very low, and no trials were at a low risk of bias, suggesting clinicians should tailor these therapies to individual patient profiles. Moving from functional disorders to pediatric inflammatory bowel disease, a multicenter retrospective study in the American Journal of Gastroenterology evaluated the safety and effectiveness of early anti-tumor necrosis factor, or anti-TNF, therapy in children hospitalized with active internally penetrating complications, such as abscesses and inflammatory masses. Out of 203 children, 43% received early anti-TNF therapy within 30 days of diagnosis. The study found that early anti-TNF was safe, showing no association with increased infectious or non-infectious serious adverse events, and it significantly increased the likelihood of achieving combined clinical, biochemical, and corticosteroid-free remission by more than 60%. Crucially, among patients who underwent percutaneous drainage, adding early anti-TNF therapy dramatically reduced the risk of subsequent surgery, with an event-free survival rate of 58%. Compared to just 15% in those who received drainage alone. This strongly supports early initiation of biologic therapy within a multidisciplinary framework for pediatric patients with penetrating complications. In the realm of adult inflammatory bowel disease, long-term surveillance after restorative proctocolectomy is a critical clinical focus. A 2-institution case control study in the journal Inflammatory Bowel Diseases investigated whether endoscopic inflammation of the rectal cuff increases the risk of subsequent neoplasia in patients with an ileal pouch anal anastomosis. Comparing 46 patients who developed pouch or rectal cuff neoplasia with 184 matched controls, the researchers found that patients with rectal cuff inflammation on their initial pouchoscopy had nearly 3 times the risk of developing subsequent neoplasia. This risk was even higher, nearly 4-fold, in patients with persistent cuff inflammation across multiple examinations, whereas those with transient resolved inflammation did not show a significantly elevated risk. These findings suggest that persistent cuff inflammation is a strong risk factor for neoplasia, highlighting the need for aggressive anti-inflammatory treatment and closer endoscopic surveillance for these patients. Our second theme explores how endoscopic techniques perform in clinical practice, ranging from diagnostic yields to procedural classifications and therapeutic interventions. First, a prospective, multicenter clinical trial, which typically recommend upper endoscopy and colonoscopy, but omit small bowel evaluation. In 170 patients who underwent all 3 modalities, including small bowel capsule endoscopy, the diagnostic yield of capsule endoscopy for potential bleeding lesions was 50%, which was significantly higher than the 28% yield for upper endoscopy and the 20% yield for colonoscopy. Overall, pan-gastrointestinal endoscopy identified potential bleeding lesions in over 70% of patients, directly changing clinical management in more than half of the cohort. This suggests that the small bowel is a highly common site for bleeding lesions in patients with iron deficiency anemia, and that capsule endoscopy should be considered earlier in the diagnostic algorithm. While diagnostics are advancing, standardizing how we describe what we see remains a challenge. A prospective multicenter video-based study in the American Journal of Gastroenterology evaluated the reliability of the laterally spreading tumor, or LST, classification for large colorectal lesions greater than 2 centimeters. 24 expert endoscopists from around the world independently classified video-recorded tumors. Surprisingly, the inter-observer agreement was poor, with a kappa value of only about 0.37. Even when looking at inter-observer reproducibility, the results varied widely. Simplifying the morphology into a basic 3-category granular versus non-granular classification only modestly improved agreement to the moderate range. These findings suggest that clinicians should exercise caution when using detailed LST subclassifications for making clinical decisions or predicting submucosal invasion, as the current classification system lacks sufficient diagnostic reliability among even expert endoscopists. In therapeutic endoscopy, a multicenter retrospective study in gastrointestinal endoscopy evaluated the clinical outcomes of primary versus conversion endoscopic ultrasound-guided gallbladder drainage using electrocautery-enhanced lumen-opposing metal stents. In patients with acute cholecystitis who are at high surgical risk, endoscopic ultrasound-guided gallbladder drainage is often preferred over percutaneous drainage. Comparing 117 patients who underwent primary endoscopic ultrasound-guided drainage to 24 patients who underwent conversion endoscopic ultrasound-guided drainage after initial percutaneous drainage, the study found no significant differences. Technical success was extremely high in both groups, at 98% and 96% respectively, and clinical success, adverse event rates, and long-term stent patency were also highly comparable. This demonstrates that converting from percutaneous drainage to endoscopic ultrasound-guided gallbladder drainage is a safe and highly effective option when a primary endoscopic approach is not initially feasible. Our final theme addresses infectious pathogens that drive chronic gastrointestinal and hepatic disease. In a major publication in Gut, researchers utilized 2 large randomized trial cohorts in China to clarify the relationship between Helicobacter pylori infection, its treatment, and colorectal cancer risk, and how this risk is modified by host genetic susceptibility. Analyzing data from over 180,000 individuals, the study found that untreated Helicobacter pylori positive individuals had a significantly higher risk of colorectal cancer, a risk that was particularly pronounced in those with high genetic risk as measured by a polygenic risk score, or those infected with specific virulence factors. Long-term follow-up over nearly 30 years in one cohort showed that Helicobacter pylori eradication therapy halved the risk of colorectal cancer, with an even greater risk reduction of over 60% among those with successful eradication. In the second cohort, while there was no overall benefit after 14 years, a protective effect was clearly observed in individuals at high genetic risk or those with specific virulence factors, suggesting that Helicobacter pylori eradication may have a broader role in colorectal cancer prevention than previously recognized. Finally, managing infectious liver disease in high-risk populations remains a global health challenge. The STOP-C trial was a large precision randomized trial in India evaluating the impact of hepatitis C treatment adherence support among 3,000 people who inject drugs. All participants received a 12-week course of daily sofosbuvir and velpatasvir and were stratified by a prognostic risk score into minimal or elevated treatment failure risk before being randomized to high, medium, or low-intensity adherence support. Surprisingly, the overall sustained virologic response, or SVR rates, were suboptimal, ranging from 60 to 68% in the minimal risk group and only 45 to 51% in the elevated risk group. High-intensity support, which included patient navigation and flexible directly observed therapy, only showed a modest benefit in the minimal risk group and had no significant impact on SVR in the elevated risk group. These findings indicate that standard adherence support programs are insufficient for this highly vulnerable population, highlighting an urgent need for more intensive or novel strategies to achieve hepatitis C elimination. If you only have time for one paper this week, make it the multicenter prospective study on iron deficiency anemia from gastrointestinal endoscopy. This study challenges our diagnostic paradigm by showing that half of these patients have potential bleeding lesions in the small bowel, a rate significantly higher than those found by standard upper endoscopy or colonoscopy. demonstrating that small bowel capsule endoscopy should be integrated much earlier into the workup of unexplained iron deficiency anemia. Here are the key takeaways from this week in gastroenterology. First, for patients with irritable bowel syndrome, gut-brain neuromodulators, particularly SNRIs and TCAs, and brain-gut behavior therapies like dynamic psychotherapy and cognitive behavioral therapy offer the highest probability of symptom improvement, though the overall quality of evidence remains low. Second, early anti-TNF therapy is safe in children with penetrating Crohn's disease complications, and when combined with percutaneous drainage, significantly reduces the need for subsequent surgery. Third, persistent, rather than transient, rectal cuff inflammation in patients with an ileal pouch-anal anastomosis is associated with a nearly four-fold increased risk of subsequent neoplasia, necessitating aggressive inflammation control and vigilant surveillance. Fourth, the current laterally spreading tumor classification system for large colorectal lesions suffers from poor inter-observer agreement among experts, suggesting we should rely on simplified morphological categories for clinical decision-making. Finally, Helicobacter pylori infection is associated with an increased risk of colorectal cancer, and eradication therapy can significantly reduce this risk, particularly in patients with a high genetic predisposition. That's your roundup for this week in gastroenterology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.